Welcome to this Pure Voice activity. To access the entire activity, including supporting material, go to www.purevoice.com/fbm. This activity is supported by an educational grant from Bayer AG. Bayer AG has had no involvement in the selection of the speakers, the development of the activity, the agenda, or the materials.
Hello, I'm Ashkan Shwamnesh. I'm a stroke neurologist at McMaster University and a senior scientist at the affiliated Population Health Research Institute, Hamilton, Canada. It's a great pleasure to have with me today my colleague, Dr. Professor Zhen Cheng from Huashan Hospital, Fudan University in Shanghai, China. We will discuss together the current standard of care for secondary prevention after non-cardioembolic stroke or high-risk TIA. Before we start, I'd like to comment that in prior peer voice activities, approximately 30% of learners were able to identify the approximate risk of stroke recurrence within 12 months after a TIA or minor stroke. Let's now have a look at the data. Now, some data that supports the correct answer is the ASTRIS registry, which was a multi-country registry conducted within the UK and Denmark, as well as Japan. And here we're only showing you the data for the UK and Denmark, where patients with minor ischemic stroke or TIA who were discharged from hospital were followed, and it was shown that the rate of stroke recurrence ranged between 7 to 8% and increased with increasing age. Now, it's worth noting that the early recurrent rate in the hospital is not being captured in this data. Dr. Cheng, can you please take us through the trials that support the role of DAPT in patients with minor ischemic stroke or high-risk TIA? And later on, we'll discuss how this has influenced guidelines.
Sure. In clinical practice, we have long recognized that the single antiplatelet therapy is often insufficient to prevent secondary stroke. Therefore, since the MATCH trial published in 2004, investigators have been exploring dual antiplatelet therapy, DAPT. And the MATCH trial showed that the long-term DAPT increased the risk of life-threatening or major hemorrhage. Subsequent studies, including Chang's, Point, Taylor's, Inspires, and Chang's 2, enrolling patients with earlier minor stroke or high-risk TIA, typically within 12 to 72 hours from symptom onset, and tested short-term DAPT. These studies found that early short-duration DAPT can reduce recurrent ischemic stroke, and a 21-day DAPT regimen does not increase the risk of hemorrhage.
Great. Thank you so much for that nice summary. I wanted to highlight that in past Pure Voice activities, 40% of learners were not familiar with the optimal duration. And could you please maybe take us through the results as to what has led us to now think that 21 days may be the most ideal duration in the majority of patients?
Yes, as we can see from the rightmost plot, we can see that the light blue line represents major ischemic events, and the dark blue line represents major hemorrhage. And the absolute number of major ischemic events prevented by clopidogrel plus aspirin exceeded the increase in major hemorrhage, particularly within 3 weeks of treatment. Therefore, the pooled analysis of Chang's and Point trials further confirmed the benefit of DAPT appears to be largely confined to the first 21 days after minor stroke or high-risk TIA.
And are there any populations, Dr. Cheng, where you may go beyond 21 days in your practice?
Yes, especially for large atherosclerosis stenosis patients, we will use DAPT for 90 days.
And that's particularly intracranial athero?
Yes.
Yes, yeah, great. And here we're showing really a flow diagram that incorporates all these trials that you just discussed, Professor Cheng, as well as the latest guidelines that have been informed by those trials. And essentially, the first question that's being posed is whether someone has symptomatic intracranial atherosclerotic disease at a cutoff of 70 to 99%, which was the eligibility criteria for the Sampras study. Here, the recommendation is clopidogrel and aspirin for 90 days. If patients don't have symptomatic intracranial atherosclerosis, we then are posed whether the patient has an ischemic stroke and then that's being stratified by an NIH stroke scale of 3 or less, or 4 or 5, depending on the eligibility criteria of the trials that informed those two different pathways. But really, in the end, it doesn't matter, right? You're either using clopidogrel or aspirin for 21 days, or ticagrelor or aspirin for 30 days. And then similarly, when you're looking at TIA, here the stratification is occurring according to the ABCD2 score, and again, being informed by the different eligibility criteria across these studies. But ultimately, the options are the same, either clopidogrel and aspirin for 21 days. And it's also worth mentioning that in certain populations where we expect them to have higher loss of function alleles that lead to poor metabolism of clopidogrel, ticagrelor would be the favored P2Y12 inhibitor, and that's being supported by the CHANCE-2 study. Now, how about patients with symptomatic intracranial atherosclerosis? Do they benefit from other interventions like intracranial stenting? What is the best data say to date?
Yes, so beyond the medical treatment, investigators have also been exploring whether percutaneous angioplasty offers better secondary stroke prevention than medical therapy alone in patients with TIA or ischemic stroke due to symptomatic intracranial atherosclerotic stenosis. However, in the CASIS trial, angioplasty and stenting did not further reduce recurrent stroke compared with medical therapy. And in a more recent trial, BASIS trial, investigators found that balloon angioplasty could reduce long-term stroke recurrence. However, as we can see from the figure, that the risk of stroke or death within 30 days was higher than with medical therapy alone. And the procedural complications occurred in about 70% of the patients, and the arterial dissection occurred in 14%, suggesting that the safety of the procedure still needs further improvement.
When we think about optimizing stroke prevention, we really focus our discussion here on DAPT predominantly, or antiplatelet therapy, but it's really a multi-pronged strategy, isn't it? What are some of the targets that you think about, Professor Chang, in your practice for these different risk factors?
Yeah, I think these targets are quite reasonable. So I usually emphasize the blood pressure below 130 and 80, even though the patient may have intracranial or extracranial large atherosclerosis stenosis. And also the LDL-C level below 1.4 millimole per liter, and good control of blood glucose. Yeah.
And now please answer this challenge question. So to really bring this all together, optimal stroke prevention in patients with non-cardioembolic ischemic stroke is really a multi-pronged strategy that even gets individualized to the person and patient who's in front of you. This includes antithrombotic therapy for the majority of patients, DAPT for 21 days, followed by long-term monotherapy is the appropriate approach. However, in certain individuals, that may extend to 90 days, particularly in patients that have intracranial atherosclerotic disease. And then, of course, if you're concerned about metabolism of clopidogrel, ticagrelor would be a more favored P2Y12 inhibitor in that option. But that multi-pronged strategy also includes optimizing glycemic control, lipid-lowering therapy, antihypertensive therapy, and really a holistic approach that also includes lifestyle measures that improve their diet, exercise, stress control, smoking cessation, weight loss, as well as ensuring adequate sleep, all play into optimizing stroke prevention. But despite our best efforts, the data still shows that the risk of recurrent stroke remains substantive in this population, about 6 to 7% per year. So we still have a large unmet need for further therapies and further strategies that can reduce stroke in this population. And now please answer this challenge question. Well, thank you very much, Professor Chang. I really enjoyed our discussion today. Thank you all for watching. In the next episode, Dr. Weitz will explain the potential role of factor 11A inhibition in secondary prevention after non-cardioembolic stroke or TIA.
Hello, I'm Dr. Jeffrey Weitz. I'm a hematologist at McMaster University in Canada. As you previously heard from Dr. Schwamanish and Cheng, there's an unmet need for secondary prevention after non-cardioembolic ischemic stroke and high-risk TIA. I would like to now discuss why factor XIa inhibition may offer new avenues as a target for secondary stroke prevention. Before we start, I'd like to comment that a previous peer voice activity demonstrated that 60% of learners were able to recognize the key rationale for factor XIa inhibition as a potential target for secondary prevention in non-cardioembolic stroke. But now I'd like to go over why this works. So remember that coagulation can be activated through two distinct pathways. The tissue factor pathway, this is the pathway that's activated when plaques rupture, and the contact pathway or intrinsic pathway, this is the pathway that's activated when blood comes into contact with a negatively charged surface. The two pathways converge on the common pathway. Now, the factor XIa inhibitors have the potential to uncouple pathologic thrombosis, which is intravascular clot formation, from physiologic hemostasis, which is mostly extravascular clot formation, to seal the holes in blood vessels that can occur from outside-inside injury. Hemostasis is triggered by the high concentrations of tissue factor surrounding the blood vessels. This results in explosive thrombin generation and fibrin formation and doesn't involve factor XI. In contrast, pathologic thrombosis is triggered by low concentrations of tissue factor, which induce the formation of small amounts of thrombin, and that then, the fibrin that forms covers up the injury site, but then the thrombin feeds back, activates factor XI to generate more thrombin, more fibrin, and this causes the clot to expand and block the blood vessel. Our current anticoagulants target clotting factors in the common pathway, and as a result, they not only block the thrombotic process, but they also have an effect on hemostasis and can lead to bleeding. In contrast, the factor XIa inhibitors attack the thrombosis pathway because that's where factor XI activation is important for clot growth, but factor XI isn't important for hemostasis, so these can block thrombosis without affecting hemostasis, thereby uncoupling the two processes. The support for factor XI as a target comes from data from people with genetic deficiency of factor XI. They're protected from thrombosis and they rarely have spontaneous bleeding. Mendelian randomization studies tell us that people with high levels of factor XI are at increased risk for thrombosis, and those with low factor XI levels are at decreased risk for thrombosis and rarely have serious bleeding. And animal studies show that if you knock out factor XI or you inhibit it, you can attenuate thrombosis in arteries or veins, but you cannot induce bleeding. Now, factor XI inhibitors come in various types. We're dealing with the small molecules like asundexian and milvexian, which bind reversibly to the active site of factor XIa and block its activity. But there are also antibodies that bind to factor XI and block its activation or its activity, or antisense oligonucleotides that reduce the hepatic synthesis of factor XI. And now, please answer this challenge question. Thank you for watching. Hello, I'm Dr. Jeffrey Weitz. I will now discuss the concept of dual pathway inhibition. Before we start, I'd like to comment that In past peer voice activities, 64% of learners were able to correctly describe the results of the COMPASS trial, but we'll get into this in more detail as we move along. You've already heard that there's a risk of recurrence after non-cardioembolic ischemic stroke or transient ischemic attack. The current standard of care for these disorders is antiplatelet therapy. Despite the best antiplatelet therapy, there's a high risk of recurrence over the next 6 to 12 months. This is where the dual pathway inhibition comes in. Current standard of care is antiplatelet therapy, but now in dual pathway inhibition, we add an anticoagulant to antiplatelet therapy with the idea that the clots are formed of aggregated platelets and of fibrin. So we use the antiplatelet therapy to attack the platelet component of the clot, and we use the anticoagulant to reduce thrombin generation and fibrin formation. So together, the two have a chance to be better than either component alone. And this concept was shown in the COMPASS trial, where patients with stable coronary or peripheral artery disease were randomized to receive aspirin alone, the standard of care, a combination of aspirin plus low-dose rivaroxaban, or rivaroxaban alone. And the study showed a 24% reduction in the primary efficacy outcome of cardiovascular death, stroke, or MI with the combination therapy. The problem with the combination was that there was an increase in bleeding, not an increase in fatal bleeding, but an increase in major bleeding, which decreases the appetite for this type of therapy. So the concept is that by using a factor 11A inhibitor on top of antiplatelet therapy, we can get safer antithrombotic efficacy with the dual pathway approach. And now, please answer this challenge question. Thank you for watching.
Hello, I'm Dr. Xin Chen. Dr. White explained earlier what factor 11A inhibitors are. We will now have a closer look at the design and the results of the two phase 2 trials that use factor 11A inhibitors, asundexian and milvexian, as potential strategies for secondary prevention after non-cardioembolic stroke. Preclinical studies with each of these molecules have shown promising results in terms of safety and efficacy, which led to the phase 2 trials. Before we start, I'd like to comment that in the past peer voice activities, nearly 30% of learners were able to identify which finding from the Pacific stroke trial with asundexian led to the phase 3 OCEANIC-STROKE trial. Let's now look at the data. And the AXIOMATIC-SSP was a phase 2 trial that recruited participants with ischemic stroke, NIH score less than or equal to 7 or high-risk TIA, ABCD2 score 6 or 7, were randomized to one of 5 doses of milvexian or placebo for 90 days. And the participants also received clopidogrel 70 mg once daily for the first 21 days and aspirin 100 mg for 90 days. And the primary efficacy outcome was a composite of ischemic stroke or incident covert brain infarct on MRI scan at 90 days, and no significant difference was observed between milvexian and placebo. Furthermore, no significant dose response was observed among the 5 milvexian doses for the key secondary outcome, which is symptomatic ischemic stroke. And the main safety outcome was major bleeding at 90 days, and no apparent dose response was observed for major bleeding, and also no increase in major bleeding between milvexian and placebo. The Pacific stroke was a phase 2 trial that examined different doses of asundexian 10 mg, 20 mg, or 50 mg once daily versus placebo, in addition to usual antiplatelet therapy in patients with a non-cardioembolic stroke within 48 hours from symptom onset, and were followed up during treatment for 6 to 12 months. The primary efficacy outcome was the dose-response effect on the composite of incident MR-detected covert brain infarcts or recurrent symptomatic ischemic stroke at or before 6 months after randomization. No significant difference was observed between asundexian and the placebo. However, for the post-hoc exploratory outcomes, there was a dose-dependent reduction of composite of ischemic stroke or TIA with asundexian. Patients with atherosclerosis, no matter intracranial or extracranial atherosclerosis, had fewer recurrent stroke and TIA with asundexian 50 mg. The primary safety outcome was major or clinical relevant non-major bleeding defined by ISTH criteria. And you can see that no significant bleeding outcomes in patients treated with asundexian versus placebo. And now, please answer this challenge question. Thank you for watching. Hello, I'm Dr. Xin Chen. I have discussed how results of phase 2 trials with Factor XIa inhibitors milvexian and asundexian have led to the phase 3 trials, LIBREXIA-STROKE and OCEANIC-STROKE, respectively. Now let's take a look at the design of these 2 phase 3 trials. Before we start, I'd like to comment that in the past Pure Voice activities, approximately 15% of learners were able to identify the cutoff NIH score criteria used in LIBREXIA-STROKE and OCEANIC-STROKE trials. Now let's look at these 2 phase 3 trials. So, LIBREXIA-STROKE is a randomized double-blind parallel group placebo-controlled phase 3 trials conducted across 838 sites in 47 countries. The target sample size is 15,000 participants, and the patients were recruited within 48 hours from symptom onset and randomized into 2 groups, milvexian 25 mg twice daily, plus background antiplatelet treatment, and or they were randomized to placebo twice daily plus background antiplatelet treatment. And the study duration is up to 46 months. And the primary endpoint is time to the first occurrence of ischemic stroke, up to 41 months. And the primary safety outcome is major bleeding. And the main inclusion criteria is that they recruit the patients with ischemic stroke or TIA within 48 hours from symptom onset, and the stroke severity is mild, NIH score less than or equal to 7, and high-risk TIA, ABCD2 score 6 or 7. And the major exclusion criteria are they want to exclude patients with prior intracranial hemorrhage, cardioembolic stroke etiology, non-atherothrombotic cause of stroke, for example, in the TOSA classification, other determine the category, and also increase the bleeding risk patients. And for OCEANIC-STROKE, this is a randomized double-blind placebo-controlled phase 3 trials, and they recruited patients between January 2023 and February 2025. Altogether, 12,327 patients were recruited, and the patients were randomized into 2 groups, asundexian 50 mg once daily plus background antiplatelet treatment, or placebo group plus antiplatelet treatment. And the primary endpoint is ischemic stroke, and the primary safety outcome is ISTH criteria defined major bleeding. And there are also a couple secondary efficacy and safety outcomes. So the major inclusion criteria for OCEANIC-STROKE is the patients have the stroke within 72 hours from symptom onset, non-cardioembolic stroke, and with an NIH score less than or equal to 15, or high-risk TIA, ABCD2 6 or 7. And they also exclude the patients with history of atrial fibrillation or other cardioembolic source require anticoagulation, and ischemic stroke patients within 7 days of the index event, or strokes following procedures or end-stage renal stenosis and other active non-trivial bleeding events. And as you can see from the figure below, that the cumulative incidence show that asundexian reduced the recurrent ischemic stroke by about 26%, with an effect that appeared early and was sustained throughout the treatment period. And for the secondary efficacy endpoints, including all stroke, cardiovascular death, and the composite of vascular outcome of cardiovascular death, all-cause mortality, myocardial infarction, or stroke, there were clear reduction in the asundexian group. Because there was no significant difference between the groups in recurrent ischemic stroke at 90 days, the final secondary endpoint was not formally tested. However, numerically, we still can see the asundexian reduced disabling or fatal stroke as well. And for the primary safety outcome, ISTH criteria defined major bleeding, there was no significant difference between the two groups. And also for other secondary safety events, including symptomatic intracranial hemorrhage, non-major bleeding, minor bleeding, there are also no signal of the increased bleeding risk in the asundexian group. And now please answer this challenge question. Thank you for watching, and Dr. Shamanesh will discuss in the next episode more details around the participants and subgroup analysis of OCEANIC-STROKE.
Hello, I'm Ashkan Shwamanesh. Let's now go into a bit more detail into the patient characteristics of the OCEANIC-STROKE trial, as well as subgroup interactions. So OCEANIC-STROKE was a large global initiative conducted at over 700 hospitals in 37 countries, where 12,327 participants were enrolled. Baseline demographics were equally distributed between the two treatment arms and is largely representative of the target population. The mean age was 68. 33% of the population was female, which is less than you would expect. However, unfortunately, it is a common theme in secondary stroke prevention trials that we have underrepresentations of females, but still a large number of females got into the study, 4,000, from which to look at in terms of benefits and subgroup analyses. The 20% of the population had a prior history of stroke or TIA, 16% had coronary artery disease, 80% were hypertensive, a third were diabetic, and a quarter were current smokers. Looking at the qualifying event, 95% of the population had ischemic stroke at study entry, and 5% had TIA. This is similar to the 9% that was seen in the Thales trial that also required an ABCD2 cutoff of 6 or greater, as opposed to some of the other dual antiplatelet therapy trials that required a cutoff of 4 or greater. When we look at ischemic stroke subtypes under the umbrella of non-cardioembolic ischemic stroke, we find that the majority of patients, 43%, had large artery atherosclerosis, 30% had stroke of undetermined etiology, and 22% had small vessel occlusive disease-associated strokes. Strokes of other etiology and cardioembolic strokes were not eligible for the study. However, many of these patients were identified to have these stroke mechanisms after randomization. So a small proportion, 3%, also had stroke of other etiologies, and about 2% had cardioembolic strokes. And then the stroke severity at baseline had an NIHS median of 2, interquartile range of 1 to 4. There was a large proportion of patients who received revascularization therapy within the study. 27% received either IVTPA or EVT, and 2/3 of the population were due to receive dual antiplatelet therapy versus single antiplatelet therapy in the remaining a third of the population. We've already shown you in a prior session the impressive primary safety and efficacy results of this study, where randomization to asundexian led to a robust 26% reduction in the hazard of ischemic stroke without any excess in major bleeding or even other bleeding outcomes like minor bleeding in this study. And really, we want to know that in a large population such as OCEANIC-STROKE, are there any subgroups that are behaving differently? And as you can see, really across the board, whether you're looking at age, sex, geographic region, race, history of hypertension, diabetes, whether someone had a prior history of stroke or TIA other than the qualifying event, history of atherosclerosis, vascular imaging of atherosclerosis. It didn't matter whether either of these were present or not. Patients benefited from asundexian. Similarly, it didn't matter whether you had brain imaging demonstrating an acute non-lacunar infarct, whether your qualifying event was an ischemic stroke or TIA, the qualifying ischemic stroke subtype, time from symptom onset to randomization, whether you got revascularization treatments, baseline stroke severity, or whether you were due to receive dual antiplatelet therapy versus single antiplatelet therapy. We also dove deeper into stroke subtype because in our phase 2 study, there was some suggestion that patients with atherosclerosis may have greater benefit from asundexian. We looked at host criteria for the 3 key subgroups of interest: large artery athero, small vessel occlusive disease, stroke of undetermined etiology, including patients with embolic stroke of undetermined source. And what we found is that there's consistency in the treatment effect across all ischemic stroke subtypes. All of them benefited both for the primary efficacy endpoint of ischemic stroke, but also for all stroke as well as disabling stroke, without any excess in the ISTH major bleeding, intracranial hemorrhage, or hemorrhagic stroke, which interestingly was numerically less with asundexian versus placebo in all ischemic stroke subtypes, including patients with small vessel occlusive disease who had greatest risk for this endpoint. And lastly, when we looked at patients with embolic strokes of undetermined source, this is where we saw the largest reduction, with a 47% reduction in the hazard of ischemic stroke, statistically significant result, but no heterogeneity effect with a p-value being above 0.05, meaning these patients benefited similarly to the overall population, again without excess in major bleeding. And now please answer this challenge question. Thank you for watching. Hello, I'm Ashkan Shwamanesh. I will now describe a patient case and discuss further the unmet need for secondary stroke prevention after non-cardioembolic stroke. But before I do that, I wanted to highlight that in past peer voice activities, approximately 25% of learners were able to identify the key limitation of long-term dual antiplatelet therapy beyond 90 days compared with single antiplatelet therapy for secondary prevention of non-cardioembolic stroke. This is the case of Helen, who's a 67-year-old woman with evidence of ischemic stroke. She presented to hospital approximately 6 hours after symptom onset with some difficulty with speech, as well as mild right-sided hemiparesis of the face and arm. Interestingly, she also expressed that she had some gait imbalance that lasted 2 hours, 12 days prior to presentation, suggestive of maybe a TIA at that time. When looking at her medical history, there is a flavor of atherosclerotic disease in that although she's hypertensive, she also has coronary artery disease, type 2 diabetes, and dyslipidemia. Her medications include antiplatelet therapy with clopidogrel, lipid-lowering therapy with rosuvastatin. She is on 2 blood pressure agents and metformin for her diabetes. The neurological assessment in the emergency room demonstrated an NIA stroke scale of 4 due to dysarthria, as well as weakness of the right face and right arm, as well as very mild aphasia. An MRI of the brain is shown here, and what you're seeing is punctate infarcts in the anterior circulation border zones bilaterally. As you'll see, ACA, MCA border zone, punctate embolic apparent hits in the left frontal lobe, as well as a more subacute region in the right ACA, MCA border zone. And this likely reflects the symptoms she had about 12 days earlier, where she had some difficulty with balance and walking for 2 hours. And although the symptoms resolved within 2 hours, and this would have been historically considered a TIA, on the basis of this MRI findings demonstrating an infarct that correlates with those symptoms, it does actually make this likely that this was actually a minor ischemic stroke with rapid resolution of symptoms. When we further investigated this patient, we found that she had non-stenotic atherosclerotic disease of the bilateral carotids and aortic arch with ulcerated atheromatosis disease of the arch. Her ECG was normal sinus rhythm. She also underwent 72 hours of cardiac monitoring, which was unremarkable. And overall, her echo was uncontributory. There was an EF of 62%, which was normal, and only a hypokinetic segment of the anterior wall of the left ventricle, which we often see in patients with non-cardioembolic ischemic stroke. Her vital signs were overall normal, but her blood pressure was running higher than the target, particularly in patients with someone who is diabetic, at 138/85. If you recall, the target should be less than 130/80. And her lipid profile is also slightly above what it should be. Her LDL is 1.97 millimoles per liter. Her target should be less than 1.8 millimoles per liter. As you saw, her rosuvastatin dose was 40 milligrams, so the highest eligible or therapeutic dose of this drug. So this would be a case where you can add ezetimibe, as we discussed in the guidelines. But her glycemic control is appropriate with an HbA1c of less than 7. When we think about the duration of DAP that would be best served for her, based on this landmark analysis of the point study that we discussed, really the biggest benefit is going to be within the first 21 days, but certainly on the basis of the high-risk plaques that she has with the ulceration and the arch, there are physicians out there who will consider even going to 90 days in patients who have a high-risk plaques that seem to be unstable. So really what we see is that patients with non-cardioembolic ischemic stroke remain at high risk of a recurrent event. That risk is substantive in this patient with her aortic arch disease. I would suspect at least 7 to 8% risk in the first year. But fortunately, that risk can be reduced by another 25% without any compromise in bleeding based on the OCEANIC-STROKE results. And we're very eager to have asundexian available to be able to address this unmet need. And then there is also this ongoing LIBREXIA-STROKE results that we believe will likely be confirmatory and also a positive study, allowing milvexian to also be a second option, hopefully, for our patients in the near future. And now, please answer this challenge question. And thank you very much again for watching.
This has been an activity published by Peer Voice.